today, I think, four in all, and we received them after the official deadline, but we've worked really hard to try and refer to them. So my colleagues, my exec colleagues, will be able to answer those questions when they take their segment. And for any that we don't cover, we will respond within directly by email within the required time. So I think we've got 15 members of the public who've signed up to attend today's meeting, in addition to the standing invitation offered. So let's please move on to declarations of interest, if I've covered everything. Please, can members here update us on any extra declarations of interest or anything not formally declared that pertains to this agenda that we need to cover? I've got one hand up. Sandra, please. Sandra Grant.
Thank you. Sandra Grant, I'm the Chief People Officer for Bob ICB, but I also hold the Regional Workforce Director role for NHS England at the moment. I think there aren't any very obvious conflicts, but if any arise during the meeting, I'll raise them at the time. Thank you.
Thank you, Sandra, for making that very clear to us and noted. I think there's one thing that we have noted and we want to make sure that the public are aware of, and that is Nick Broughton is currently not on the Frimley register of interests, and there's an action underway to get that over. Obviously, he's on Bob, but we need to register that under the Frimley ICB as well. So we will do that. Thank you. Moving on, we've submitted the draft minutes to the Bob meeting in public on the 9th of September and the Frimley meeting that took place on the 16th of September. So can I ask colleagues, please, are you happy, and members of the public, are you happy with the minutes and the summary of the meetings that we held? Are there any amendments or any points of accuracy that anyone would want to bring up at this stage? Perhaps others will help me with hands as well. I can't get through everybody's, but I don't see any. So I think we'll adopt those minutes, please. Thank you very much. And then moving on to item 3, before we do that, actually, I will be moving the agenda a little bit in order to capture the presence of a couple of our executives that need to move on to national meetings. I'm going to bring item point 8.2 forward so that we can cover that off, if that's all right, ladies and gentlemen. But before that, I will ask Nick to come in with any updates regarding the system at the moment. Thank you.
Sim, thank you for that, and good morning, everyone. For those who don't know me, I'm Nick Broughton. I am the Chief Executive of the Bob and Frimley ICBs, and I assume the role of Chief Executive of Frimley on the 1st of October. I will take the report as read, but just really wanted to flag that since our two boards last met in public, it was announced that the proposed merger of NHS Buckinghamshire, Oxfordshire, Berkshire West ICB with part of NHS Frimley ICB to establish the new Thames Valley ICB will come into effect on the 1st of April next year. And in keeping with that, the clustering arrangements between our two organisations came into effect on the 1st of October. And that is when I succeeded Sam Burrows as the Chief Executive of Frimley, and just want to put on record my thanks to Sam for all he did whilst leading the Frimley ICB. This very much reflects the scale of change that's ongoing across the NHS at the present time. There is an awful lot going on, and that's reflected by the detail of the report. And in keeping with that, we received a question from Tom Lake highlighting concerns regarding the scale of change and the importance of the NHS maintaining and further developing a fair and open learning culture. Mr. Lake asked what role the ICB would play in doing that across our system, and to reassure him, the ICB has an important role to play as a system leader, and we also have an important role that we continue to discharge in terms of oversight of quality across all our providers. So we will play an important role in developing the right culture across the wider NHS, and we will do that through our system leadership role and by also ensuring that the ICB as an organisation has the right culture. And this is very much a focus of the work that we're progressing in relation to organisational development. And in terms of who's ultimately accountable for this, who's ultimately leading this, it will fall on me as Chief Executive of both organisations and of the future organisation to provide that leadership. I'm not going to say anything further, Sim, very conscious that there's a lot to cover in today's agenda, but we'll just ask any of my executive colleagues, is there any particular points they want to flag now, or rather leave until later in today's agenda?
Thank you, Nick. Let's bring in Ben. I think he's got his hand up. Yeah, thank you.
Hi, thank you. Yes, Ben Riley, I'm the Chief Medical Officer for Bob ICB. I thought this might be a good moment to address the question that we had from Mr. Etkin relating to the Chief Exec's report. So thanks, Mr. Etkin, for your question. The question was regarding how the ICB is going to ensure that the development of neighbourhood health services aligns with NHS England's strategic commissioning guidance, including the 10 principles that place the voices of staff, people and communities at the heart of decision making. And I'd like to assure you that those principles are very much central to how we design and develop neighbourhood level health. Just very briefly, the principles 1 and 2 are about early and meaningful engagement, and we're committed to starting engagement as early as possible in planning, recognising that much of the work is already happening through place partnerships to do that, and that does include working with local residents and their elected representatives, community groups, GP teams, local authorities and a wide range of stakeholders, including the voluntary sector, to understand people's needs, priorities and lived experiences. And as the plans develop, that will include public workshops and other targeted outreach activities for seldom heard communities, as well as structured opportunities for patients to shape proposals as well. The principle 6 that you referred to in the question is about clear and accessible information, and we are constantly reviewing our communication methods to ensure that we're communicating with people across different communities as clearly as possible, including through our partners as well. That also includes local media, social media, and both digital and non-digital means of communication. And our comms team endeavours to ensure all our information is presented in as clear and understandable way as possible. And then the final section of the principles are about co-production and accountability, and the ICB strengthening its approach to co-production as a sort of business as usual way of working, and we talk about that in our commissioning intentions document, in fact. And it's really important that people with real life experience, as well as people who work on the front line of NHS services, are directly involved in shaping neighbourhood health models. And it's important to note as well, I think, that the neighbourhood health plans will be owned by health and wellbeing boards and include local government representatives and Health Watch in developing those plans to represent the voice of citizens as well. So in summary, we are very much committed to ensuring neighbourhood health services are not only designed for local people, but with them. And if any members of the public would like further detail on any aspect of that, or to be involved in future engagement, please do get in touch and we'd be happy to provide more information. Thanks.
Excellent. Thank you, Ben. Really, really clear and helpful. Let me move on then, if there are no other updates that colleagues want to provide at this stage. And we said that we would take item 8.2 to profit from Sam still being here. So perhaps, Sam, I could bring you in then as Managing Director of Frimley to help us with the EPRR Annual Assurance Report, which needs approving. Thank you.
Thank you, Sim. Good morning, everybody. For those who don't know me, I'm Sam Burrows. I'm the Managing Director for NHS Frimley. And just for the Joint Committee to be clear, this item only pertains to NHS Frimley ICB, not to both organisations. Firstly, could I just say thank you to Richard Chapman, our CFO, for holding the accountable emergency officer role for the organisation whilst I was in my interim chief executive position. Extremely helpful, and this report pertains to that period as well. So Rich, big thank you from me. This is a really simple and straightforward item. It's a part of our category 1 responsibilities as an emergency responder. And as a part of our NHS Frimley internal assurance process, we do seek the board to take an annual position of oversight and approval for the status of the organisations within our geography. That includes the ICB itself as well. So we have in the report in your paper bundle a summary position of the EPRR compliance for both NHS Frimley as an ICB, but also 3 provider organisations as well. You will see those 3 organisations are Frimley Health Foundation Trust, NHS Berkshire Healthcare Foundation Trust, and HCRG, which is one of our main community healthcare providers. I'm really pleased to say that all 3 organisations are substantially compliant with the national and statutory core standards. This is the same position that was reported last year as well. And you will see that in the vast majority of the 58 core standards, or 62 in the case of FHFT, that we are very close to almost universal compliance across the board. So I'm not prepared, Sim, to give any further detail than that. Happy to take any questions that board members may have. But just to be really clear, 3 asks of the board this morning. 1, please just to note that position of substantial compliance. 2, that where we do have 2 or 3 outstanding areas for further progress to be made, that we have a plan to address those inside the ICB and with our provider organisations as well. And thirdly, that by bringing this report through to the board for approval this morning, that we've met our own internal assurance process as well. So that's all from me. Thank you, Sim.
Thank you, Sam. Very clear on the asks. So I'm asking members of the Frimley board, please, to approve. So to note the compliance, as Sam said, the areas that are still non-compliant, to note the plan that we're working to cover that, and the internal assurance, own internal assurance has been met. So can I have a show of hands? Are we happy to approve this, members? Thank you, Nick. Yeah, thank you. Thank you, Hugh. Excellent. Okay, no dissent on this. Oh, Graham, please.
That was my hand.
I'm sorry. Perfect. A wonderful hand. I accept it willingly. Thank you. Without comment. Thank you, Graham, for pointing that out. And I think, Sam, you've got the approval that you need, and we've noted. And thank you for staying and taking that item early. Let's move back then to the main agenda. So we are on item 4.1, and this is finance planning and transformation reports for Bob and Frimley. So quite rich. So I think, Rich, you are going to take us through this, please, and we'll follow with the quality reports, the workforce report, and I think we're taking these reports as read, but just give us some top lines, please.
Thank you, Sim. So top lines, both ICBs, both systems are out on plan at month 6 financially. But both require a material improvement in their expenditure run rates to remain on plan and to deliver the planned break-even position. There is commonality in pressures on both sides, particularly in the areas of Section 117 right to choose ADHD assessments and independent sector elective activity. Both Frimley and Bob are taking appropriate remedial actions to affect a change to those emerging cost pressures. In terms of the in-year position, both ICBs are behind on their planned delivery of efficiencies, and it's clear that both will now, to a fairly material extent, be reliant on non-recurrent in-year solutions to deliver a break-even position at the year end. And teams are working on drawing up those landing plans to close the identified gaps. I did want to note that the introduction of the new ledger in ICBs, which was required by NHS England, has not been as smooth as was hoped, and that has caused a range of material issues which have impacted both ICBs' ability to report and to manage the financial position. In terms of the providers, all providers across both systems are currently on plan year to date. But again, in the face of the demand that providers are facing, there are material challenges to delivering an in-year break-even, and that is particularly true at all 4 of the acute trusts. In terms of performance, the data available shows that we are largely on track with our 18-week referral to treatment target, but a bit behind with 52-week waiters, and well cited on that, and we are taking action across both systems to bring that back into line. For cancer on 28-day diagnosis, both Systems are largely on track. For 62 days seen, there are some issues. So Frimley is ahead of plan, Bob is a bit behind plan, and again, action being taken to deliver that. And finally, on 4-hour waits in EDs, performance very similar. Bob at 75.5%, Frimley at 75.3% against a target of 78%, but all providers fully cited and taking actions in conjunction with the systems around them. Happy to take any questions.
Thank you, Rich. Does Matthew or Mark want to come in? Sorry, Mark's not here, but Matthew, anything to add?
Just add perhaps a little bit of a provider context where we've got pressure. So it's probably worth noting, obviously, the data is month 5, but on UEC, we've seen continued good performance going into October across the system, with Bob being ahead of plan and Frimley slightly below on the latest numbers. But actually, we do very well on the regional winter preparation and safe winter discharge across the 2 systems, which I think is bodes well for going into winter. We have seen a deterioration in the SCAS Cat2 position over the last couple of months since the data formally reported to board. Richard mentioned we're broadly on target, but a couple of specifics challenges we've got. So on RTT, BHT are behind plan, and for the overall waiting list and RTT, and our interim, which is regional support. So we're meeting fortnightly to work through that recovery plan. The latest position is BHT are hoping to recover that position by the end of the year. There is a key national target on the 21st December to get rid of 65-week waits, and all trusts have submitted plans that are compliant, broadly compliant with that deadline. There are a few outstanding issues on Oxford numbers, but we're working through that with them. On the cancer, as Richard mentioned, we are struggling on 62-day as a system. We've now been in tiering for over 2 months. We are seeing some improvement, but we've also seen some challenges over the summer around capacity and vacancies. So that doesn't feel yet like a stable improvement picture, but there are some areas where we've seen improvement. And I probably should just mention that obviously we're in a period of industrial action at the moment. So credit to our providers for managing that well. We've seen similar absences around resident doctors across the system, and we believe, yet to have fully validated data, but we believe the Trust have done a really good job of protecting elective capacity. So we're hoping for minimal impact on wait times. Thanks.
Thank you for that extra information. Let me take, if I could take the 2 questions together, one after the other, and then we'll ask Rich and Matthew to attend to them. So first of all, Sajed, and then Susan. Thank you. Sajid, I can't hear you. I don't know if others can. Sorry. No, we can't hear you properly.
Can you hear me?
Just, yes, not very clear, but better.
Sorry, let me speak up a little bit. So thank you for the updates. Just a combination of...
Can't hear you. Sorry. None of us can hear you. Let me take Susan. You try and sort that out. Susan, please.
Thanks very much. So I'm Susan Parsonage, Chief Exec at Woking Borough Council and partner member representing local authorities. It's about the performance report. I wanted to ask, can we include benchmarking information in there alongside the performance, i.e. how we compare against others in the South East? Thank you.
Has Sajid come back? No. Okay. Who would like to take that?
So I'm happy to take that. Sorry, I've realised I didn't introduce myself last time. Matthew Tate, Chief Delivery Officer for Bob ICB. I think we're looking to develop the performance report, Susan, so we're happy to look at that. We do get quite a lot of benchmarking information, and if we can't always include it in the report, I think it's a good challenge to make sure we give context when we present. So for UEC, for example, we are amongst the top performers across the South East region. For elective, we perform well, with the exception, as I mentioned, of BHT. But happy to take that away, work with Rich and the BI team about how we incorporate more benchmarking.
Thank you.
Nick, did you want to come in?
Yes, I just wonder whether this is a good opportunity to address the question from a member of the public regarding the performance and quality report and the fact it's a little leaner than in previous months. Matthew, are you able to pick that up?
Yeah, of course.
Thanks, Matthew.
So we've changed sort of from the Bob ICB. We've changed. We've moved from an outsourced support for business intelligence to actually working with Frimley colleagues as they develop the new model for the Thames Valley ICB. So I did want to formally say thank you to colleagues for stretching in and supporting that over the last few weeks. So as a start point, we've mirrored the key metrics within the Frimley report, so that does look different than previous Bob reports. The timing issue, I think important to note that we do bring published data to the board, and that will always be a significant period behind in terms of alignment with the date of the board meeting. So we will work to align that as best we can, but there will always be a lag, and that will depend on our board meetings. So some of this is about planning our joint committee and board meetings to get the most up-to-date data. But hopefully, as I've tried to do today, we will bring more recent data to life, so the board are cited on more recent trends.
And just to confirm, the question regarding the report came from Mr. Tom Lake again.
Thank you, Nick. Sajid, I think you're back. Please ask your question.
Can you hear me now, Sam?
Yes, much better. Thank you.
Thank you. I think it might have been answered, but just Rich, your level of confidence factoring in the big step up in terms of savings that we have to achieve in the second half, the industrial action, whether there's a worse winter than you were forecasting back in March and February when we did the budgets, just your overall level of confidence?
It's extremely tight, Sajad, tighter than I've known it. I think we are adopting a very disciplined methodology to deliver landing plans across the system. So I've had detailed discussion with the CFOs of the providers. We are all adopting the same format, producing a year-to-date extrapolation, normalizing it, and then looking at what the gaps are, what the action plans underpinning the closure of those gaps are, who will do what by when, and mapping it on a monthly basis. So it's really tight. I think we are doing everything that we possibly can to make sure that we are able clearly to articulate the challenges and the actions that we're taking to close them, and we'll just keep working to do so.
Thank you.
Thank you, Sajid. Good question. Thank you, Rich. If there are no further questions, Susan, did you want to ask another one?
I just wanted to ask another one on the performance report, or just make a point. There's quite a few of the measures that don't have targets against them, and I'm assuming that will be addressed at a future point, and particularly where there's a performance that needs to be improved, for example, around learning disability and health checks.
Yeah, happy to respond to that. So we'll take away any gaps where we haven't included an actual target. There are some areas in the performance report where there is not a target as such, and they're not a national target. So we need to work through that, Susan. So I think probably in the report, happy to pick it up. So we've got a couple of examples, maybe one or two where we haven't quite got the target in the report yet, but there will also be one or two others there where there isn't a national target to respond to, and it's almost looking at a trend perspective.
Thank you.
Thank you. So Matthew, will as you look at the way that the information is presented, will that be ready for presentation at next public board, or do you need more time to work through the slight changes and amendments or additions?
There will be improvements and changes as we go through and develop it. As I have said, the team have worked really well to get the report where it is today, but there's still a couple of alignment issues to work through. So we will see a development next time. So.
Excellent. Thank you very much. Moving on then, quality report and the workforce report. Again, take the reports as read, but just if you could bring out or enhance any of the things that you are concerned about or that you feel this board needs to be very clear on. Thank you. I'll introduce Sarah first.
Excuse me, Chair, would it be appropriate or able for Dr. Kumar to present his neighbourhood report, because he is scheduled for this time and he's in practice this morning?
Right, so to bring forward item 5.1?
Yes, because that's when he was scheduled for now. So that'd be really lovely if you.
Okay, yes,
do that.
yeah, no problem. Welcome, Dr. Kumar, and we understand your timing, so please do. You're going to introduce the thing, Sarah, the agenda item.
Welcome, Baron. Baron's come to present on the Slough National Neighbourhood Project that we've initiated. So over to you, Baron.
Yep, brilliant. Is anyone able to share the slides? Because I'm not allowed yet. Brilliant. Cool. Can I control? Okay, great. So thanks everyone for joining. I'm Dr. Baran Kumar and I'm representing the GPs in the neighbourhood space. So I'm Clinical Director for Shape Primary Care Network and I'm primarily based in Slough. So I'm going to walk you through the neighbourhood health approach across East Berkshire with a particular focus on Slough, and I'll cover why Slough was chosen, what the data tells us, what we learned from previous pilots, and how we're building a community-led, insight-driven model for diabetes, CVD, and wider neighbourhood health. So here's the baseline challenge. Healthy life expectancy across Frimley varies significantly. Slough consistently sits around 10 years lower than neighbouring areas, and that gap tells us there are deep-rooted health inequalities. And it's exactly why neighbourhood health level work matters. This slide really sets the context for everything that follows. Can I change slides? I don't think so. Yeah, brilliant. So this slide sets out the neighbourhood sites across the southeast that are participating in both the National Neighbourhood Implementation Programme pilot and the Regional Neighbourhood Health Accelerator Programme. And it illustrates how neighbourhood working is being rolled out systematically across all ICSs in the region. So for Frimley, we're one of the systems actively contributing to both programmes. Our neighbourhood work is part of the national NHIP cohort, and we're also represented within the Southeast Regional Accelerator. And that means that the work happening in Frimley is not operating in isolation. It is directly linked to the national testing, regional learning sets, and shared development across other ICSs. Neighbourhoods are now a key national building block for integrating primary care, community teams, and local partners. What this map shows is that every ICS in the southeast is moving in the same direction, with local areas feeding into the national programme and benefiting from regional accelerator infrastructure. So Frimley's involvement in these programmes position us as part of a wider national learning environment, influencing neighbourhood design, sharing our developments and adopting best practices from other ICSs in the region. It reinforces that our approach fits within the wider national and regional model for neighbourhood transformation. Next slide, please. Yeah, perfect. So Maidenhead PCN has been selected to be part of the Southeast Regional Accelerator Leadership Programme. And this programme is all about strengthening care around frail older people, carers, and people at risk of crisis. The aim is independence, prevention, and joined up teams across NHS, social care, and the voluntary sector. Maidenhead PCN has joined this regional accelerator, and we're aligned locally, so learning flows across all places. Next slide. That works. Yeah, brilliant. So East Berkshire and Slough were selected as Wave 1 sites for the National Neighbourhood Health Service. The focus is fivefold: target inequalities, integrate services, support long-term conditions, reduce hospital use, and empower communities. And a cross-sector project team is already in place to drive this over the next 12 months. So from the first workshop in Britwell, one thing was really crystal clear, and that people want genuine involvement. Local voluntary groups and residents really emphasise that neighbourhood health must be co-designed, not imposed. And we're deepening that commitment at the November Child Week event with over 40 community partners. Next slide. Right, so a bit of a busy slide. So we've got figure 1 and figure 2. So this table in figure 1 illustrates some high-level demographics of our ICS, which population of about 815,000, and we see the variation between Slough and other places across most metrics. Slough is younger, more diverse, with more populated households and greater levels of deprivation. It's important to note that we have pockets of deprivation across the ICS, with Rushmore as an example of an area with similar levels of deprivation to Slough, which isn't shown at the place level here as part of the NEHF, as it adjoins to much more affluent Hart and Waverley areas. And figure 2, well, the numbers reflect the prevalence of range of conditions after adjusting for age and sex and are compared to the overall population average. Purple shading shows where the prevalence is higher than the rest of the population. For example, diabetes in Slough, we see a prevalence of 11%, which is around double that of other parts of the system. The blue shading indicates where the prevalence is lower compared to the rest of the population. For example, in Slough, where we see alcohol consumption of 3.2%, which is less than half of that of other areas for this specific factor. And we see this tends to be lower or less reported in deprived areas and BAME ethnicities. So in a nutshell, Slough's demographic, younger, more diverse, more deprived, more multi-generational households. And when you adjust for prevalence, even after adjusting for age and sex, Slough shows significantly higher prevalence of multiple conditions, particularly CVD risk factors. And it reinforces that inequality isn't theoretical, it's visible in the data and the outcomes. So next slide. Perfect. So Slough has the highest diabetes, pre-diabetes and obesity rates across Frimley. Care processes and treatment target achievement is also lower. The consequence is more predictable, that we have more A&E attendances and more admissions in this cohort. And that's why diabetes is the first priority. It's a high prevalence, high cost and high opportunity for meaningful improvement. Next slide. So we're not guessing in this. There are 3 sources that guide our work: population health analytics, partnership intelligence from councils, voluntary groups and existing programs, and community insight, cultural, behavioural, environmental factors. And when we bring these together, that's when we can target the right neighbourhoods with culturally sensitive, realistic interventions. So the pilot blends community-led lifestyle change with clinical optimization. So rather than focusing only on medical interventions, we deep link community assets, faith centres, local leaders, cultural groups into diabetes care. It's about meeting people where they are and reducing barriers like language, culture, and trust. And this slide really shows the philosophy underpinning our model: collaborative, person-centred, culturally aware support. And what we've learned is diabetes is rarely a standalone issue. It sits within family, housing, lifestyle, and beliefs. So the model brings together that social, clinical, and behavioural support in one neighbourhood clinical level offer. Next slide. Yep. So the multi-generational household pilot, earlier pilot taught us a lot, that working with households rather than individuals improved health checks, screening, COP outcomes, and significantly reduced A&E attendances and admissions. Given Slough's high proportion of multi-generational homes, this approach is incredibly relevant. Next slide. This is pretty interesting. So activity levels in Slough are among the lowest in the country, especially for women, older adults and deprived neighbourhoods. And the barriers are real: safety, cultural expectations, cost, childcare, confidence. These are all issues and these are all barriers. And the Get Britwell Active programme showed us that locally tailored physical activity offers are essential when it comes to tackling diabetes and CVD. Next slide. So this slide sets out the 3 levels of prevention and why Slough is an area where targeted neighbourhood interventions can have a significant impact. So first, we have primary prevention, and this is starting. So if you take in Slough, with 57% of adults meet recommended physical activity levels, which is 13% lower than South East average. We want to stop people from becoming diabetic in the first place. We also see a greater prevalence of pre-diabetes and obesity, both of which are those major drivers for diabetes risk. So this tells us that Slough has a sizable group of people at increased risk of becoming diabetic, and these individuals aren't patients yet within clinical pathways, but they're exactly the cohorts where neighbourhood-based interventions and community activation and lifestyle support can really make that major difference. We have secondary prevention, and this is supporting people with diabetes to meet targets. So when we look at secondary prevention, the picture actually becomes more concerning. More than 1 in 10 adults in Slough now have diabetes, compared to around 7% for the Southeast as a whole. And despite that higher prevalence, Slough also has a lower percentage of patients achieving their diabetes care processes and treatment targets than the rest of Berkshire. And this increases the risk of complications, hospital use, and long-term system pressure. So this middle group, those with a diagnosis of diabetes but suboptimal control, are a key target cohort for neighbourhood working, proactive reviews, and digitally enabled recalls. And then lastly, we have tertiary prevention, which is managing complex patients and reducing admissions. So at the tertiary prevention end, Slough has a cohort of patients with uncontrolled diabetes, particularly those with an HbA1c over 100, who face a 2.5-fold increase in admission risk. And even more striking is that complex diabetic patients in Slough has 7 times greater risk of admission. And these are individuals already interacting with multiple parts of the system, and where neighbourhood teams can play a major role in coordination, case management, and complication prevention. So when we bring all 3 levels, we can start to see clear cohorts we can prioritise. People at risk of becoming diabetic, people with suboptimal control, or people who are accumulating conditions, and people with multiple complications and high admission risks. These are the groups where neighbourhood working can have the greatest impact, improving population outcomes, reducing variation, and easing that long-term burden on hospitals and the community services. Next slide, please. So this is just a 12-month timeline showing how we build momentum quickly. For example, in November, it's all about community engaging and sense checking the cohorts. As we move into December, we're going to be finalising cohorts and selecting some test and learn interventions. And then we're going to be looking at early delivery of quick wins and really sharing that learning across the other places, including Bracknell and RBWM, all with continuous feedback loops and evaluation built in. So that comes to the end, but before I finish, I just want to highlight why this is an exciting moment for East Berkshire. So everything I've shown today makes it clear that Slough has big challenges, but we also have real momentum, and we're building on genuine successes, not just starting from scratch. We've already seen what works, the impact in Britwell, the gains from multi-generational pilots, and the strength of our voluntary and community partners. And it's those successes that have given us the foundation we can now scale. And importantly, this isn't happening in isolation. Maidenhead's work in that regional accelerator program means we now have parallel learning, shared leadership, and a real chance to build up joint neighbourhood model across the whole of East Berkshire. And if we get it right, we know the benefits are clear. Better prevention, earlier diagnosis, fewer admissions, and communities who feel supported and empowered. And more importantly, we'll create this neighbourhood model that's just practical, culturally grounded, and just genuinely scalable across the other areas as well. That's all from me. Thank you.
Thank you, Dr. Kumar. I think we all welcome that in-depth view of Slough and just illustrating how neighbourhood and it is working or will work. That rich population data points us to the focus areas. And as you say, if we can use this model to help us scale across the rest of the patch, this is very important. Let me ask if there are any questions for anyone. Saqib, please come in.
Thank you, Dr. Kumar. That was incredibly insightful, and it made me reflect both on my own pre-diabetic journey a few years back, but also the multi-generational households that you referred to. And whilst you mentioned diverse households, would it be correct to say that largely these are South Asian families? And if so, then have you either drawn on experiences in putting this together, or will we be able to share experiences with other towns and communities such as, I don't know, for example, Luton or Bedford, which are near to where I live? Because obviously I'm sure these multi-generational households and the prevalence of type 2 diabetes are increasingly becoming common amongst those ethnicities.
So a couple of questions. So yes, the demographic can be mostly South Asian, but we can't forget our Eastern European population and also our Afro-Caribbean population who have high risk and rates of diabetes that we need to engage with. We have, as you know, lots of experience from the multi-generational pilot, but also digital adoption and other pilots that we've tried across Slough as well. So we already have this kind of a base to work from. And we also have a fantastic and really engaged voluntary sector who are doing all they can to use novel ways to get patients in and to engage with them. So we have a lot of experience that we have already that we're going to build. And a lot of our work is about developing closer relationship with our partners. In terms of drawing experiences from other areas, absolutely right, and that's very important, and which is why we've been invited to neighbourhood Southeast regional workshops, which are happening, I think, almost bi-monthly. So we had the first one last month, and I think there's another one in January or February. And now that's an opportunity to share learning with other similar areas. So in our groups, we had Northwest London, who cover the areas such as like Grenfell, and we've had Surrey as well, which all of these areas will have similar themes and be using some innovative models in order to build up their neighbourhood pilots. And it's a fantastic opportunity to learn and make connections. So I guess the answer is yes. We'll be using lots of experiences and showcasing our own work and learning from other people's work in the journey.
Thank you.
Conscious of time, I'm going to let Ben come in because I should have let him say something. I'm sorry, after this, and then I'll take Gareth and George's questions, and then we need to move on to let release Dr. Kumar back to surgery, I think. Okay, Ben, please.
I'll be very quick. Thank you very much, Baron, for that. I think your presentation there really illustrates the value of that sort of local understanding of your population and the population data. I was just going to ask you one really simple question, really. What do you think that the ICB could do more of to support you and your partners in delivering neighbourhood health and setting out, realising that vision you've set out?
Oh, great conversation. I mean, I think the ICB is fantastic in that space in terms of gathering key players together and facilitating conversations. And I think neighbourhood health, a big part of it is relationships. So I think it's really looking to break down some of the red tape between silo working between organisations, and really tackle some of the barriers that we've had over the last few years in terms of real connectivity and closer working. And if we all commit as players in the room and as leaders within neighbourhood health, I'm sure we'll be able to do that. And I think that's what we're looking for, is everyone has a role to play in neighbourhood health and everyone to commit to the idea of working within the neighbourhood health constructs. And that allows us to break down some of those barriers. I hope I answered your question there.
Yeah, thank you. That is very helpful.
Great, thank you. George and Gareth, one after the other, and then we can let Baron go.
Yeah, so I'm George Gavra. I'm a partner member for primary medical services in Bob. I'm also the GP named lead for the Buckinghamshire neighbourhood programme. So obviously we're in sort of NHIP along with Slough. A couple of questions. One was just in terms of the intervention side of things, just obviously you're not at a point yet where you've kind of announced what those will be and decided. Just wondered where you thought the kind of focus of delivery would be in terms of provider, how well you've engaged. Obviously engaging with VCSE, are you looking at doing that through specific providers taking responsibility, or how are you collaborating across that? And the second is, you mentioned about the sort of spreading this. Do you see this as a model for spreading regarding diabetes care, or do you think there'll be an ability to pull out lessons for other disease groups and other multi-morbidity populations? Because obviously the majority of these patients with diabetes, certainly in your secondary and tertiary group, are going to have a number of other conditions as well.
Yeah, so specifically when it comes to interventions, I think you're absolutely right. VCFE, and we're very lucky to have BHFT as a community provider, and I think between us, I think it's about looking at what interventions are quick and sustainable. And a lot of our work is not just focused on the diabetes element. Well, it is focused on the diabetes and obviously some of the clinical outcomes that I've described, but also breaking down some of the barriers and relationships which I've described as well. And if you take both of those, how we work and what we deliver, I think we'd be confident that we could then, that learning can transcend into other areas, and whether that's a different clinical area or actually, is this a way we can approach another challenge, whether it's estates, whether it's access to diagnostics? The journey is equally as important as the outcome in this process.
Thank you, Baron. Did we lose Gareth? I can't see him on my screen, so I presume no further questions then.
Indeed, I'm here, but the
Oh, I'm
question
so sorry.
was gladly answered. I was very much aligned with Ben that we would. This is the Dr. Kumar, you did a fantastic job, and I'm sure there's lots of folks on this call that would want to support you in the next phase. And just to add, it's not just because action is necessary. In my view, inaction, it doesn't just keep the baseline as to where things are now, which is untenable. It's going to get worse. So I don't see an alternative, but really dedicated, neighborhood action. So anyway, congratulations on the presentation. It was fantastic.
Thank you very much, Gareth. I think it's very kind of you. Thank you.
Thank you, Gareth, and thank you, Baron. I think you can hear the sentiment and the encouragement, and it's good to see the detail. And we'll be pleased to welcome you back when we start seeing some impacts. Thank you.
Thank you, Sim. I'll leave now. Thank you very much.
Bye. Thank you. Thank you, Sarah. I think we just need to quickly go back to item 4.2, don't we? Just very quickly, Sarah and the workforce team, please, and then we can strike off that. Thank you.
Thank you, Chair. Just one quick point, because I think it was raised by a partner colleague that it wasn't that clear in relation to the complaints data. We've tried to bring together a quality report across Bob and Frimley. The complaints data is done by two separate teams and done in different ways, and therefore the way it's recorded is different. And it might appear that Frimley have significantly more complaints than Bob do, but the reality is that Frimley have 77 complaints and Bob have 199. So what you would expect, just for clarity.
Thank you. Thank you very much. Let's take the workforce report and then we'll take any questions over the items then.
Thanks, Sim. So I'll start with the system, very quick highlights on that and go into the ICBs. So the system is performing well from a workforce plan perspective. For Bob, it's to plan and delivering well, and for Frimley, it's just very, very slightly over plan. Obviously, we're keeping a close watch on that because of the industrial action and going into winter pressures, but it's a positive message at the moment, and we worked really hard to make sure we had realistic plans as much as we could in that space. So we are hopeful, but we'll still closely monitor that. With regard to ICBs, obviously lots happening in that space. You'll see that from the workforce data that you've got there that it's mostly the staff are attending well and performing well. So we are doing well with regard to absence, for example, and turnover. We have, you would have remembered in previous months, we would have shared the fact that we were releasing a mutually agreed resignation scheme. And just as we were concluding that, the announcement came that we could now release a voluntary redundancy scheme. For some people, it's more favourable to shift into the voluntary redundancy scheme. And as people hadn't finished the whole of that process, we wrote to each of them that had the Mars applications proceeding to say, if that was a better choice for you, you can withdraw from Mars and submit a voluntary redundancy application. There is no guarantee that's approved, obviously, but we are just going through that process with staff. There were less than 30 staff impacted by that, so it's not a huge number, but of course it's an important decision point for each member affected by that. So the voluntary redundancy, as you would have seen probably from lots of the national press, we are launching that tomorrow for staff to be able to apply, 2-week window. And the intention is that we progress through that. We go to regional approval for most of those cases. And then we permit people to leave at a point that works for them and us, but predominantly that will be within this financial year. So that's what's happening in voluntary redundancy space. Just two other things I quickly wanted to mention. We are doing an interim values refresh so that we have an aligned approach for Frimley and Bob that will help inform things like our selection processes going through into the new structure. So we will come back to board to share the progress with that. And we have just completed our staff survey across Bob and Frimley ICBs. Lots of really important messaging there from our staff, particularly around how the change process is and what they would like to see more and less of. So again, we'll come back to the board with messaging from that in the future. Thank you.
Thank you, Sandra. Thank you, Sarah. Any questions in terms of workforce or quality at this stage? I can't see any hands up. Maybe others will help me. No. So I think just thinking about, oh, Nick, sorry.
Yeah, just very quickly, Sim, I'm probably stating the obvious, but there's an awful lot going on, and colleagues working across both organisations are under a lot of pressure, and that is superimposed on the uncertainty that they have regarding their own futures. So I'm very grateful for their continued dedication and commitment during what are probably unprecedented times in most people's careers.
Thank you, Nick. Well said. And this board is completely aware of the scale of the challenge, both financially, performance, and from a people point of view that all of you are under, and in fact, our teams. So we thank you for supporting them in the best way possible. It is an almost it is almost an impossible task, but we note the scale of the challenge, and we can see the areas of risk in terms of finance, but note the mitigations that are there. Thank you. If there are no further questions, then let's move forward. So we're looking at planning now, 26-27, and I think, Rich, you're up again, and perhaps Hannah will come in as well.
I think it's the other way around, Tim.
Oh, it is
Hannah's
the other way
gonna lead
around.
out as the more talented member of the duo.
Excellent.
Thank you. So I'll just do a couple of slides. This is a bit of a process update as the kind of sandwich between the commissioning intentions, which we published in October, and the plans that we're currently developing. So obviously we're forming the Thames Valley ICB, and the key purpose of the Thames Valley ICB is to be a strategic commissioner and to make sure we're using our commissioning levers to best effect to meet our population's needs, and within that reducing health inequalities and ensuring equity of access wherever our residents live. So that's really our guiding principle to how we engage with planning and how we think about it. And I think Baron's presentation was brilliant in teeing this up, and Prash's comments in the chat in terms of the kind of key driving purpose of this is how do we make sure more of our 5 billion is going towards supporting neighbourhood health? How do we do that in a way that doesn't destabilise existing provision but redirects it and also changes the way we meet demand in our population? So those are the kind of things we're thinking about, but obviously we're delivering this at a time of change. If we move on in the slides, thank you. So in terms of national context, we wrote this slide and we said we're still waiting for financial allocations, but hot off the press, we've received those today. So the kind of real nuts and bolts of planning can begin. And all of these documents here show you the level of kind of national attention on planning and the role of the ICB, which we need to kind of absorb and then think about what does that mean for the Thames Valley. And again, here we're trying to get the balance between our kind of strategic intent and doing things differently, and also recognizing that you can't change everything overnight. So what are the kind of key things we need to start shifting this year? Locally, if we just move to the next slide, we set out a vision in our, this is the timeline we need to work to, which is very ambitious, but we'll just skip over that. But we've got a core team who are working on this. I was going to say night and day, which shouldn't be the case, but unfortunately is often the case with planning. If we just go to the next slide, thank you. So as the board will be aware, and partners on the call too, we developed our commissioning intentions, and we've got kind of 3 driving aims here to help us move to a more sustainable system. We want to think about how we're commissioning to maximise value, and that means every pound we're spending for our Thames Valley population, we're thinking about equity and making the most of that in terms of the effectiveness of interventions and moving to more of a neighbourhood model. And that's our second aim here. And as Ben put in the chat, we're moving to a kind of neighbourhood offer for the Thames Valley, so every resident can expect the same kind of core offer, even if it's expressed differently where they live. And then finally, we want to be proactive in terms of investing in prevention. So how are we doing this in a time of change? In the next slide, thank you. There's 2 main inputs in developing our plans. So we're working closely with our provider partners primary care, place partnerships and provider collaboratives, and we're kicking off some of that deep kind of discussions today, so that we can build and triangulate our plans together. And secondly, within the ICB, our leads are coming together across the Bob and Frimley teams to develop a Thames Valley view on our strategic priorities. And all of our planning decisions are going to be framed this year by 4 principles, which link to our commissioning intentions. So there's one of value, there's one of consistency of offer for the Thames Valley resident, there's one of equity, and there's one of financial sustainability. And so what we're going to do is set up a process that we will triage contract renewals, commissioning decisions through those principles, and work out how we move this year to a more kind of equitable offer for our population, and also identify the kind of strategic ambition for future years. So finally, I'll just move to how we're delivering this. Sam, could I have the next slide? Thank you. So this is a lot of work, and we're doing it in a time where there's a lot of other work going on. But in terms of the role of this board, this is the accountable body for the plan, for the use of that 5 billion. And so we're going to need to make sure that we work with board members, and we build kind of public engagement and transparency into the decisions we're making. We're going to set up a Thames Valley Planning Board so that we can make sure we're sticking close to our decisions around those principles. And I'm going to be discussing that with the Bob and Frimley execs tomorrow. We've already got a planning forum where we bring together our teams, and we've already got a core planning team. And the enablers and the activities give you a sense of the kind of work in train to make this real. The final slide just gives a sense of what the board's required to be assured on. And this is around the key kind of statements we'll need to sign off on are: have we commissioned the right level of activity for our population to achieve the performance improvements we need to? So it's very important that we have a watertight understanding of the capacity in our system, what's required to deliver the targets, and therefore what different planning decisions we need to make. So this is the work underway, and I hope that gives colleagues on the call a flavour of it. As I say, a process update today, but I look forward to getting into the kind of granular detail of planning and how we support neighbourhood health in future meetings. Thank you.
Thank you, Hannah. Complicated process, complex, a bit new, but very well presented for all to see. And I'm sure that we feel assured around the area of how you will include others in the thinking and the forward thinking. And I think that's very important. Let me bring colleagues in. Are there any questions, points of clarification for Hannah, or anything else that anybody wants to know? No? Okay, you did a very good job, Hannah. Thank you. I've got Susan. Thank you.
Sorry for coming in a bit late there, Chair. Hi, Hannah. Could you remind me, and I know you will have said it before, about your thinking about engagement with local authorities. I know you mentioned place partnership, which is brilliant. I know local authorities are part of place partnerships. It's just if you could say some more about that would be helpful, because I know this is the commissioning intentions. It's been a really short time scale, and there's been a lot of pressure around that. But it would be really helpful if you could say some more. Thank you.
Thank you, Susan. So there's different ways we're doing that, but I think there's room to do more as we move into the next phase. And so be really happy to meet with you offline and define how we might do that. I think on an ongoing basis, we've got those place discussions, and we're also really closely working with the Thames Valley Directors of Public Health. And we're thinking about how we develop a joint unit. So ideally next year, we'd be a more integrated team using the same data, thinking about how you bring together plans at different levels. I think there's something for me about having a more ongoing dialogue with local authorities rather than just doing it when we've got set pieces to present, because it's more of a kind of proper conversation. So happy to pick up offline with you how we do that.
That makes sense. Thank you, Hannah. Thanks, Hannah.
Thank you for that clarity. So yeah, so a bit more of a continuous conversation is the sort of action you're trying to get to, Hannah, with that. Thank you. If there is no further comment, then let's move on. And again, we're talking about change. So we're looking at the transition programme now. And I'm not sure if it's Caroline or Alison that's going to lead for us on this.
It's me, Sim, Caroline. I'm Caroline Corrigan. I'm the Chief People Officer for Frimley ICB, but I'm also covering for both organisations. I'm SRO for transition. I'm going to take it that colleagues have had time to read the paper, and I'll just focus on three things and pick up a question from a member of the public, Thomas Lake. In terms of the paper itself, just to highlight, we had on the 13th of October a checkpoint meeting, a review with NHS England colleagues about our progress regarding transition, so scope and scale, covering everything. There was very positive feedback to both the governance, the infrastructure and the leadership. Jointly we're providing for both organisations as we work through all elements of transition and change in order to close down Frimley and Bob ICBs, merge and create the Thames Valley ICB April the 1st next year. That includes the transfer of people, assets, liabilities, contracts to partner or ICBs in the south, or what's referred to in the paper as the southern transfers, to Hampshire, Isle of Wight and to Surrey, Sussex. So a complicated programme of work. We now have, in addition to this joint committee in governance terms, a transition programme board as a subcommittee that governs the detail of the transition programme. So NHS England signing off clean bill of health and positive progress given the complexity and speed at which we're working. An update in the paper, it talks about those southern transfers, the transfers of people, functions, liabilities to Hampshire, Isle of Wight and Surrey, Sussex. Hampshire, Isle of Wight, we've been having more issues in terms of gaining agreement about those transfers. We have now made a positive step forward since the paper was written, and has enabled us to engage and do the engagement with staff that will be in scope to transfer, particularly to Hampshire, Isle of Wight. So a brief update there that there is now positive progress on those transfers to Hampshire, Isle of Wight. The other big change since the paper was written is that we've received funding, all ICBs have received funding for the cost of change or redundancies, and specifically for launching a voluntary redundancy programme. That was briefed to all staff in both organisations and formally launches tomorrow. That is specified for voluntary redundancies at this stage, and both the Transition Programme Board and both remuneration committees will be kept up to date as we progress through using the nationally determined scheme and implementing that. So those are the two main highlights since the paper was written, the southern transfers and the launch of voluntary redundancy, and as I say, a good checkpoint meeting with NHS England colleagues. The question that's come in from a member of the public, Thomas Lake, was about the potential for transfers. So if we think about the model ICB blueprint, it sets out potential transfers of functions to other bodies. Obviously with the close down of the CSU announced now nationally, there's a rather complicated programme of which functions potentially transfer where and when, not just the CSU, but potentially within systems and also across ICBs. That's very active work, but the specific question that Thomas raised was about the nature of those transfers. There comes a point where a transfer is determined and then employment law applies so that that function and those people transfer from one body to another. At the point of transfer, there would not be reductions in those teams, but any new employer can, after a given period of time, 6 months plus, 12 months plus, make further changes. So Thomas highlights the complexity of the landscape potentially on transferring functions. The question posed was, could redundancies happen? No, not at the point of transfer, but new employers can make changes further subsequently. So the risk is transferring and then making redundant individuals and then potentially rehiring them. So we're aware of those risks. We mitigate those risks, and at the point of any function being identified to transfer, at the point employment law applies at that point. So that sits in. Happy to take any questions on other detail that's in the paper, and hopefully that answers Thomas's question as well.
Thank you, Caroline. Very clear. Are there any questions, colleagues? No, anything that we want to ask? Okay, so we note the decision and the considerations of the Transition Programme Board that were taken on the 4th of November. Thank you, Caroline. And that programme summary, which is in the appendix as well. That's in Appendix 1. And we note all the other updates. And thank you for keeping us informed. Thank you, Caroline. Let's move on then. My understanding is that we need to, or we just want to note on agenda item 8.1 that the policies on assisted reproductive treatments, ART, for those into acronyms, for infertile patients has been approved during the private session. So if there's no other questions, I will move on, but we wanted board to make sure that they saw that that had been approved. Okay, so I think I'm moving on to safeguarding governance, and Sarah, is that correct?
Thank you, Sim. I think the paper sets out the safeguarding governance for how safeguarding is undertaken across the ICBs. And this was in relation to a partner member question from the last public board. So it probably just says what it does on the tin. So I don't know if you just want to take questions.
Thank you, Sarah, and thank you for giving us context and reminding us that this was driven out of the last board. So can I ask, please, for any comments or thoughts on the paper in terms of it setting out the safeguarding governance arrangements for us? No thoughts or questions. Then we will move ahead then, since time is pressing. Thank you, Sarah, for laying that out for us. And we note that paper as requested. Moving on then to the board assurance frameworks, we have two approvals that need to be made, and that's the BOB paper, the BAF, the board assurance framework, and then the same for Frimley. The good news is that the Frimley BAF has already been approved by Paul, the deputy chair, in his capacity as deputy chair. So I'm asking for approval from those who are here from BOB. Rich, did you want to say anything about either of the BAF?
Happy to take both papers as read, Chair.
Fine. Okay, so questions, please. Concerns, thoughts, worries, anything that people would like to cover here? No, I'm not seeing hands. Then we will take those as approved, Rich, please. Thank you, colleagues. Thank you for that. Then further, the Joint Committee Assurance reports. We are just noting these. Audit and risk, system productivity. Is there anything that the chairs would like to say on any of those? Alex or Iona? I think Iona's not here. If not, we'll take them as read and ask colleagues for questions or thoughts. Anything on Bob? No. Anything on Frimley, audit and finance? No. So we note those reports and those papers. Thank you. Thank you very much. May I ask, is there any other business or anything that people would want to mention that hasn't been thus mentioned yet? Sakib, yes, please.
Yeah, I just wanted to thank the exec and all the staff of Bob and Frimley and working with our partners with everything they're doing during this really challenging and difficult time with the various demands that are on them. And we've heard about the Mars and VR and other such things, but it's obviously a really tough time that everyone's dealing with. So as a NED, I'm really grateful for that.
Thank you, Saki. We're very, very well said. We're all uncomfortable with this level of challenge. But let me bring in Nick. I'm sure we'll want to say something about that too.
Yes, Saki. So firstly, many thanks for that. And just building what you said, we are in the midst of a sort of transition period as we work towards creating the new Thames Valley ICB with a view to it going live on the 1st of April. And the meeting today is a reflection of those transition arrangements and the first time the two boards have met as this joint committee. It's fair to say it is work in progress. We're trying to ensure that we utilise the time and the resources available as effectively as possible, but also ensure that we have suitably robust governance in place to ensure that we are delivering on our core responsibilities, not least in terms of what we have to do in year, but also in terms of taking forward the transition programme and doing that in a suitably thorough way, and of course planning, as we touched on with the item that Hannah led on. And they are three related but challenging pieces of work, which are very much the priority areas for both organisations between now and the end of this financial year. I'm conscious that this meeting perhaps has not been ideal in terms of how much we've tried to pack into a relatively short period of time, and we need to reflect on that and think about how we can use our next meeting as effectively as possible. So any feedback to myself and Priya would be much appreciated.
Thank you, Nick. And we do note the work in progress, and we can only take heed and put things into practice and then take the learning from that. So we appreciate that it's constantly in review, and it is tough to be able to discuss so much important content in a short time, which is why it's so important, I think, that colleagues read papers and have good discussion in between meetings where we can. Caroline, you wanted to come in.
Apologies, Sim, if this is already on your mind. I think we were carving out a bit of time at the end of the agenda for Susan to give us an update, local authorities.
Yeah, I thought it was the next meeting. Sorry, Susan, what's your understanding?
It is the next meeting, that's correct, yes.
Yeah. Yeah, so not this one.
Mm-hmm.
Yeah, absolutely. Thank you though, Caroline. Thank you. Okay, so if there's no further business, my job just to remind you of the date of the next public meeting, and that's Tuesday the 13th of January at 10:30, yeah, 10:30 till 12, so 2026, colleagues, we will see you again. So just leaves me to thank all of our exec, all of the senior management team, our partner members here, everyone that's contributing to this seismic shift that's happening within the NHS, and just the patience with which we all need to approach the work that's being done, and the mindfulness of the pressure and the challenges, and the fact that everyone is doing their best to deliver this. So thank you, and thank you members of the public for attending. See you in January. Thank you.
Thank you.